There's one other thing that I think is a problem in medicine in general. New England Journal of Medicine had an article back in the 60s that looked at 1,000 people out in the community, and only one of those people ever ended up in a tertiary care medical center. And all of the practice of medicine actually happens outside of those ivory tower walls. And 99% of the research dollars that we use in medicine go to those ivory towers, and about 1% goes to the 999 people that are out in the community.
I am firmly nestled in an ivory tower cocoon. I'm on the faculty of Harvard Medical School, I write for the New England Journal of Medicine, and I practice inpatient cardiology in an academic setting. So who am I to take on a topic like primary care when, as you just heard from Ed Bugeaud, so much of it's practiced in the communities? I think that's a very fair question. I thought about it a lot when I was reporting on primary care. So when Ed, a longtime family physician in Granite Falls, North Carolina, reached out and suggested that maybe I'd be a little less negative about primary care if I spoke to someone in the community, I replied immediately. The numbers Ed cites are from 1961. They come from a seminal study published in the NEJM called The Ecology of Medical Care. And though I can't give you an accurate breakdown of tertiary versus community-based care today, it wouldn't surprise me if those numbers have changed. Meaning, as the types of care we can deliver at academic medical centers has expanded over the decades, there have been more efforts to expand access to these innovative therapies. And that's a really good thing. But even absent updated statistics, I think the basic point from the 1961 paper is still true. We, in academia, are often blind to the nature and needs of community practices. And that divide, in my opinion, can obscure some of the aspects of primary care that are the most gratifying. The crazy thing, though, is that this severing of academic medical centers from the communities we serve wasn't an accident. When Abraham Flexner set out to reform medical education in the early 20th century, one of the driving forces, which will sound familiar to anyone today, was a societal distrust of expertise. Now, back then, there were many reasons for this distrust. One was unscrupulous physician behavior due to a lack of regulatory oversight. But in an attempt to increase the rigor and scientific focus of medical education, Flexner advocated for replacing community-based practitioners, who were then central to medical education, with full-time salaried faculty devoted strictly to research and training. Not everyone was wild about this idea. And in 1911, the legendary William Osler wrote a letter to the president of Johns Hopkins outlining his concerns. I cannot imagine anything more subversive to the highest ideal of a clinical school than to hand over young men who are to be our best practitioners to a group of teachers who are, ex officio, out of touch with the conditions under which these young men will live. The danger would be the evolution throughout the country of a set of clinical prigs, the boundary of whose horizon would be the laboratory, and whose only human interest was research, forgetful of the wider claims of a clinical professor as a trainer of the young, a leader in the multiform activities of the profession, an interpreter of science to his generation, and a counselor in public of the people in whose interests, after all, the school exists. And so, 110 plus years later, here we are. I don't think it's possible to exaggerate how much the science produced in U.S. academic medical centers has improved the health of the population all across the world. But when I read Osler's words, in the midst of widespread distrust of medical expertise, alongside a smoldering crisis in primary care, I can't help but wonder, was Osler totally right? Yes, science and its translation into medical therapies can be life-changing. But so too is having a doctor who knows you, your family, and the community in which you live. To be clear, some primary care residencies at academic medical centers have done an exceptional job placing their trainees in community-based practices. But a lot of students make decisions about their careers long before then. So if we don't expose them to the joys of community practice, how will they ever know? I'm Lisa Rosenbaum, and this is Not Otherwise Specified from the New England Journal of Medicine. Before we dive into the nature of community practice and how we might better integrate it into our educational systems, I want to say one more thing. I really welcome your feedback, both positive and negative. I think it is so important for all of us to engage with our critics. And in fact, I think one of the root ills of society is that we don't. So we have a new email for the show, nos@nejm.org, and I'd love to hear from you. I've heard from some of you already, and I want to address one factual matter. In episode 4, in my conversation with Ben Davis, I referred to a statistic from a 2024 Milbank scorecard on primary care that I'd read, and I said that only 21% of primary care residents end up practicing outpatient primary care. And as one of you pointed out, this statistic may mislead by overstating the problem because the denominator includes several types of residencies, like internal medicine, which train many doctors who never intended to practice primary care in the first place. That said, the Milbank scorecard also notes that most of residency training occurs in hospitals, whereas most primary care is practiced in the community. And that's what we're going to be talking about today. So back to Ed Bugeaud, who did a family practice residency in the Air Force, spent 4 years in the military, and then actually decided to do a residency in anesthesia with the plan to do operating room procedures in the morning and family practice in the afternoons. But when he was a chief resident, something wasn't sitting right. First, he found himself providing anesthesia during surgeries that he wouldn't have recommended in the first place. And then he was called to a code that changed the direction of his life.
I was called up in the middle of the night to run a code in the ICU for a patient that had a cardiac arrest. And the code was successful, and I'd put the patient on a ventilator and put all the lines in. And then I went back to do a chart note, and I looked at the note and started reading through some of the history and physical, and the patient was 98 years old and terminally ill with a lymphoma. And I talked to the oncology resident that was sitting next to me, and I said, why did we just resuscitate this person? And his response was, that's our responsibility making those decisions. It's not yours. And we just want you to run the code and, get the patient stable, and we'll take over from there. Well, the more I thought about it, my feeling was, yes, it is my responsibility. And I didn't have a say in this whole process. And I just thought it was the wrong thing to do. It was shortly after that I actually left. I had, I think, 9 months to go in the residency, and I left before I finished. My wife thought I was crazy. My anesthesia colleagues thought I was crazy. But I knew in my heart that I wanted to be a family physician.
Ed's passion was clear, but that doesn't mean the road ahead was easy.
I'll tell you, the first year was very difficult. I borrowed $45,000 from the hospital, and at the time, you were allowed to do this as an interest-free loan. And the first year, I had $49,000 in expenses, and I had $49,000 in revenue. Didn't pay any taxes, which was good. But at the end of the year, I came home to my wife, and I said, I'm not sure this is going to work out. One thing I realized, I was probably, as a primary care physician, better trained than everybody else in 4 counties. But I didn't really understand why people weren't coming to see me. And I started to realize that you have to build a practice one patient at a time. As word of mouth spread, and I was working in the hospital, I basically did all the various forms of family practice except obstetrics, because the medical malpractice insurance was too high to do that in North Carolina at the time. But I did everything else. I had a large hospital practice. I saw people in the nursing home. I saw babies. I saw people that were 100 years old. And I started to get a reputation of somebody that, one, would listen to people, and secondly, was interested in taking care of people that were really sick, because I enjoyed that. the intellectual parts of medicine. And so each year got better.
One of the things that I think that we miss out on, both in academia and also by virtue of living in big cities, is what it's like to be a physician in a small community and really embedded in the community. And so I would love to hear from you how being so part of a community informs your practice.
A week ago, Monday, I had a patient that limped into the office, and I had a medical student with me for that month. And I said, I think you ought to go and see this patient. And she came out and she said, he's in a lot of pain. He's got this red foot, and it's tender to touch, but he's in a lot of pain and had stable vital signs. And I said, well, how would you manage this? She said, I think we ought to put him on an antibiotic and see him back in a week, and we'll see how he looks. And I said, well, I understand why you said the things you said, but I know some things about this patient that you don't. One, he's very stoic. He won't come in unless there's a real problem. And he has a fairly high tolerance for pain, and he's in a lot of pain. And that really impressed me. And I said, he's got peripheral vascular disease. I've taken care of him for over 30 years, and he was an alcoholic and he was a smoker, and we worked through all those problems, and he doesn't drink anymore and he doesn't smoke, but it's left him with other problems. He has cirrhosis of the liver. He has very bad peripheral vascular disease. And I have a feeling, just from what you've told me and what he's mentioned to you historically, that his limb is at risk for possibly developing gangrene, and he may have osteomyelitis. Even though this whole episode with the red foot and the pain just started 3 days before, and I said, we have to be much more aggressive, and we can't manage him as an outpatient. He's going to need IV antibiotics, and he's going to need an MRI of his foot, seeing if he had osteomyelitis, and then we're going to have to think about revascularization of that extremity. It was a whole different conversation, and a lot of it had to do with the fact that I've had a relationship with this guy for 30 years, and that relationship allows me to know who he is, and it colors how I might treat him, particularly in this situation.
The clinical judgment that comes from knowing someone so long is this precious feature of primary care that many thriving PCPs mentioned to me. But I also think part of Ed's clinical acumen reflects the fact that he spent 40 years seeing his own patients through both illness and health. He's long cared for his own patients in the hospital, an aspect of primary care that's become a rarity since the rise of the hospitalist movement. And though Ed may seem like a vanishing breed, this type of full spectrum primary care not only still exists in some places, but also remains really appealing to some students. Benjamin Popok is a fourth-year medical student at University of Texas Southwestern who fell in love with rural family medicine during a rotation in Mineral Wells, Texas. Like Ed, Benji thought he wanted to do something else. For Benji, it was to become a pediatric neurosurgeon after a cousin, who was like a brother to him, died of medulloblastoma. Benji was only 8 years old, and he oriented his whole life to the goal of becoming a pediatric neurosurgeon. He majored in neuroscience, worked in a lab studying neuro-oncology, went to all the neurosurgery grand rounds, and even spent time with the surgeon who cared for his cousin. But it wasn't clicking.
So at this time, I'm in my third year early on, and I'm telling fourth years and other classmates what I'm thinking and feeling, and that I'm still a little bit lost. I want to do all these things, but it doesn't seem that it exists around me. And some great upperclassmen who are going into family medicine suggest to me to try our rural site out in Mineral Wells, which is a small town west of Fort Worth. We have a family physician there who trained at my institution, as well as a neighboring one for his residency, and I decided to take the risk and apply for it. I get sent to Mineral Wells for a month of my family medicine rotation, and I'm completely blown away. I didn't realize that what that doctor was doing still existed either in this place or this time. But we may be doing, for example, a delivery Sunday night, and we're in the clinic Monday morning, Tuesday, Wednesday, Thursday. Then we're checking on patients in the hospital throughout. We schedule a patient for a colonoscopy the next week. We are really with them from the womb to tomb, cradle to grave. I've heard it sometimes said sperm to worm because you can counsel on fertility as well. And one of the critical moments for me, I remember we were seeing a patient in clinic and he's giving us all the symptoms and signs that are making us concerned for an inflammatory bowel disease. And my preceptor and I agree, and we tell the patient, I think we're going to need to schedule a colonoscopy. And you see the exasperation in this patient who's already living pretty far out of this clinic. It was already a big deal for him to come here. And he says, so now what? I need to find a gastro doctor. I need to find a stomach doctor. And we say, no, we're doing our colonoscopies. We'll be in the hospital next Wednesday. I'll put you in the schedule. And he's saying, you're going to do it. My doctor says, yeah, of course, you're my patient. And to me, that was just such a profound moment that the doctor who had taken the time to learn this, it wasn't just a frivolous biting more than he can chew, but he learned it so that he could have that moment. He deliberately wanted to be the doctor that could carry the patient through that workup to actually laying of the hands with the procedure to the treatment afterwards. All with the knowledge that if he were to find something in that scope beyond his ability, he could always refer if necessary, but that he was practicing to the fullest breadth of his capacity as a family physician was just beautiful to me. I'd never even seen that before.
So you are shadowing what I would call like the doctor's doctor, the old school country doctor. And so then what happens?
By the end of that rotation, I expressed to Dr. Agarwal, my preceptor, that I think this is what I want to do. I want to do full spectrum rural family medicine. And everything clicks. Everything makes sense to me between my outside of medicine personality being so dependent on and so involved with a variety of things to my interest in medicine. I found that it was the first time in my rotations that I was missing clinic every day, or I was missing seeing the patients in the hospital. I'd be home studying, reading their charts, excited to go back, knowing that anything could be behind that door, from the physical to social ailments that are bothering our patients.
Benji was so excited to have this clarity. His friends and family, though, not so much.
And I get back to Dallas, and I tell my friends and family, and frankly, I'm met with a bit of surprise. I'm a strong student. I've always been, and I always work hard in my classes. I'm not necessarily the top 1% of the brightest, but I've always done quite well. And a lot of folks are asking me, especially my family, family medicine, general doctor, didn't you think maybe neurosurgery or maybe now neurology, oncology, one of the, better specialties? And I'd always seen it. And frankly, I'd even thought it myself, the family docs, it's just barely managing hypertension, diabetes, and referring elsewhere. But these people didn't know. They hadn't seen what I'd seen, that what it could be at its beauty, and not just as an unrealistic ideal, but as a practicable beauty of medicine. So I really felt that at that point, I was a family medicine advocate, talking to everyone and explaining to them what I had seen, what I had done, what could be, and frankly, what I think could be in an urban environment as well. It's not that it has to be by necessity in a rural area. It's just by function, it often is, because there are not many specialists available. So the family doctor takes up this mantle. But I think that a key to improving our healthcare system overall will be the family physician adopting and taking on the burden of a full spectrum practice. Now, that's not for everyone. I certainly understand people have life commitments. People have their own interests. People may have more narrow interests and want to be more of a referral center. Perfectly fine. But to really help our patients, I believe that the full spectrum family doctor, whether rural, suburban, urban, is key.
Listening to Benji, one of the things I found most inspiring was how he described the sanctity of the physician's role in society. I know that some don't see the work as sacred anymore, especially as profit incentives increasingly shape our working lives. But I've never been able to let go of my belief in the sacredness of this doctor with a capital D role that Benji describes.
I've thought for some time about why in an urban environment there is this great deal of burnout amongst family physicians and primary care providers. And there's a number of reasons for it, but one that I've observed when comparing my differences between rural and urban medicine is that you accept a degree of anonymity in a city where in which you walk out of your clinic or the hospital and you are just a person on the street. Nobody knows, nobody cares about the charts you're going to do in your PJs that night. Nobody cares about your overwhelming workload. And that is, I think, disparaging. I think that one of the things physicians have sought for centuries, and whether consciously or unconsciously appreciated, is that they have a very unique role in a society. For many, many years, people were part of medical guilds. People were known as physicians in their areas. They were known as iatros, healers, and that was almost a divine role. It was almost a secular, divine, holy role in a town or a group of people. And that, in my feeling, justifies all the hours and hard work you put in. For me and my desire to practice rural medicine, I want to be doc. I don't want to change my white coat off and just be Benji. To me, being doc is part of my personality. And that will carry me through the less respect often given to family physicians. It will carry me through the lower reimbursement that rural family physicians or urban family physicians often receive, because that's what most people are wanting in the end. The money they think is a means to the admiration or the love or respect, but there's another means to it, and that's being part of your community and accepting the responsibilities that come with that, that your decisions are weighed heavily and you are looked at differently than many other members of the community. But that's the beauty of being a doctor with a capital D, right?
Ed, too, has played the doctor with a capital D role in his community. And you can hear in his stories how the role has enriched his own life, as well as those of his patients.
Several years ago, I had a patient that was 75 years old, and he was admitted with a community-acquired pneumonia. He was otherwise fairly healthy, although he did smoke. He started out, we put him in the hospital, and he had fever to 103, a white count in the 20,000s, left shift, and lobar pneumonia and chest x-ray. Well, within 2 or 3 days, the fever had gone down, and he was feeling really good. So I came in on Sunday morning to round on him, and he started spiking a temperature again. I thought, well, this is kind of strange. I recultured him, readjusted the antibiotics, and then I left the hospital, and I had to do some work that required me going to the hardware store to get a few things. And his niece came up to me in the hardware store, and she asked me how her uncle was doing. And, I'm not supposed to talk about that, and I probably violated some HIPAA regulations, but
I won't tell. I
yeah,
won't tell.
thank you. That happens a lot in a small town. So I said, well, he's doing well, but today he spiked another temperature, and I'm a little surprised what was going on. And she said, he's never dealt with his alcoholism, and the family's never dealt with it. And all of a sudden, the light bulb went off in my head. I said, he's in DTs, and he got agitated, and he was acutely delirious, and he had a fever. And it may have taken me a lot longer to figure that out if I hadn't had that information.
I asked Benji what medical schools could do to better elevate and encourage the type of community-based work Ed's been doing for 40 years.
I think there's a few things. I think that on a cultural level, we need to have a respect for all specialties in a way that is not necessarily elevating one or the other. It's good to recognize that some specialties really take years and years of residency training, for example, and that's wonderful to celebrate. But it shouldn't belittle any other specialties. You think managing something like hypertension, it doesn't seem as hard as learning all the steps for a resection of a very deep cerebral tumor. But then why do so many people still live with hypertension every day? There's clearly some different degree of education training that is quite difficult that even some of the best family physicians haven't mastered. I think that on the more practical side, some of what we have now is good. And what I mean by what we have now is that there are many medical schools that are churning out family physicians. In many rural areas, they have family medicine tracks where you can graduate in 3 years, and it cuts out some of the research time that, quite frankly, is not productive in many medical schools. but instead gives a little bit more clinical time, really trains people to see a broad variety and work in frontier environments. And that's wonderful. So it's great that we have those, and it's great that we have research heavy institutions that will pump out specialists. But what needs to happen is to reconcile those two and ask ourselves, what are our goals as a medical school, as a residency, as a nation in creating doctors? Is the goal to have the most prestige? Is the goal to have the most lucrative careers? Is the goal to have the most publications? If any of those are your genuine individual goals, that's wonderful. Pursue them, write all the papers, explore, research. But if rather you're doing it as a means to get to some cloudy future, I think that's wrong. I think the mad rush in some specialties to publish creates a disservice to patient in that you as a student are not spending more time in the clinic. You're not spending more time learning procedures. You're churning out papers that are pretty soon going to be all artificial intelligence augmented anyways. And everyone knows this, but no one really talks about it. If we want to keep complaining about, oh, we don't have enough specialists this, we don't have enough specialists that, is it right that we are incentivizing medical students to take a gap research year to create a year's worth of digital pollution oftentimes that is not benefiting anyone?
Recognizing some of these cultural and curricular limitations, especially when it comes to attracting community-based primary care doctors, one recently founded medical school is trying an innovative approach. The Alice Walton School of Medicine, also known as Awesome, is a new medical school in Bentonville, Arkansas, founded by Alice Walton, a philanthropist and heiress of the Walmart fortune. In the 1980s, Alice was in a car accident that resulted in some 30 surgeries and forced her to seek specialty care outside of Arkansas. Alice has been on a mission ever since, not just to increase the number of physicians in rural communities, but also to better train them in so-called whole health principles, which include the management of the mental stresses that so often accompany chronic disease. Sharmila Makija is a gynecological oncologist and founding dean and CEO of Awesome, and joined us to tell us a little bit about Awesome's innovative approach, particularly as it pertains to increasing the primary care pipeline.
So our founding principles are, the premises are focused around whole health. And what does that mean? In addition to obviously training students to understanding how to take care of sick patients, we want to look at the whole person. So we are training on how to take care of the mental, social well-being of a patient, things that are important to a patient. And that's the founding principles of the school. And our mission is to encourage the students to work in a rural background area of the state or in the Heartland region and focus really on primary care.
Sharmila also described other innovative aspects of the curriculum. For example, because so much time on traditional clerkships is typically spent in hospitals, Awesome places students in primary care clinics within the first 3 months of matriculation. Given the challenges of primary care practice, though, I asked Sharmila how they balance the desire to increase the pipeline with the realities that students inevitably observe.
I don't think it's bad for them to see the realities of medicine, right? I mean, I think that's part of the disconnect is we don't show them that. So then they think it's just them seeing it or something's wrong because nobody's talking about it or acknowledging it. We call it out front and center that you will see there are many struggles. It's not easy. It's tough. I will be teaching one section of our health system science tread about leadership and resiliency and talking about how it is, even at someone at my level, that it's real, that it's a real issue. So I'm okay with that as long as, we're also mindful that it's not a negative thing. We want them to see this is life.
Because of the financial challenges associated with primary care, particularly for those interested in independent practice, I was impressed with the curricular focus on the business side of medicine.
Now, that is a curriculum that was actually developed by the American Medical Association, and we've taken it and what we call bedazzled it, right? We've added in, enhanced it. And those are the areas that are the fundamentals of how you run a practice, basically. To finance, right? The F word that nobody wants to talk about, but that's the reality of running a clinic is understanding the operational piece of that.
Ed has not been immune to the financial and operational challenges, despite how large his practice has become. Over time, as his overhead increased and his reimbursement fell, he grew increasingly worried about protecting his employees from financial insolvency and also about protecting his patients should anything ever happen to him. So Ed started looking to hire a younger version of himself to take over the practice, but he couldn't find one. So this past April, Ed sold his practice to the UNC Health System. Of course, he still has to deal with the practical challenges many primary care doctors face, like negotiating with insurance companies. But what actually stood out to me most about the story that you're about to hear was how these little battles, when won, can in some paradoxical way be part of what makes primary care enriching.
I've been around long enough in this community. I've taken care of sometimes 4 generations. And a young lady that was 30 came in. She was the 3rd generation of this 4-generation family. And she said, I don't know what's wrong, but something's wrong, and I think it's really bad. The reason she felt that way is because everybody in these 4 generations had multiple cancers and died of those cancers. And she said, I think I've got cancer. So we did a history and an exam, and everything was normal. I mean, she's 30 years old. She doesn't smoke. She doesn't drink. And I said, well, let's just sniff around a little bit. I'll do some blood work, comprehensive blood profile. CBC said rate, CRP, chest x-ray, and got all those back. They were all absolutely normal. Urinalysis was normal, urine culture. And I said, the only thing we have left to do is probably a CT scan of the abdomen and pelvis. So I ordered that, and a couple of days later, I got a call from the insurance company, and they said, we're not going to approve this. If you want us to approve it, you're going to have to do a peer-to-peer review. And I said, okay. So next day, we got on the phone and talked to a physician and explained what was going on. And he said, you haven't checked any boxes that we use to approve stuff like this, so I can't approve it. And I said, well, wait a minute. You don't know this patient. Strong family history of cancer. You've just got to go on my gut. There's not a box you can check about my gut or a patient's feelings. And after about 20 minutes, I twisted his arm enough that he said, I don't like to do this, but I'm going to approve this. So we got the CT done, and she had a cancer of the kidney, and she had a nephrectomy.
And it was
And-
localized?
And it was localized. And so surgery was curative.
Wow.
We go through this kind of stuff all the time with prior authorization for medicines and different procedures. And I don't think insurance companies realize, we don't order these things for fun,
Right.
or for our own curiosity. We usually have a reason for doing these things. And then to put these kind of barriers in place really makes it frustrating sometimes. But I try not to let that affect my judgment too much.
I also want to be clear. It's not as if Ed is doing a bunch of unnecessary testing. In fact, Medicare came to him precisely because his costs were so low.
So I got a call from Medicare one day, and I'm really paranoid about getting calls from Medicare because they usually want money back. And I said, what are you calling me for? The person on the other end of the phone said, no, this is a good call. We're doing a study, and your practice came up in the study because you have a pretty sick patient population, but you're in the 7th percentile for cost compared to your colleagues in your specialty. And we want to know what your secret sauce is. I said, oh, well, that's a whole different discussion. I'll be happy to tell you about that.
Ed talked about how he and his staff really doubled down on team-based care so that everyone was practicing at the top of their licenses. They also focused on rigorous, guideline-directed chronic disease management and end-of-life conversations to avoid unwanted acute care admissions at the end of life.
With those sort of processes in place, over a 10-year period, I decreased my hospitalizations 80%. And our
Wow.
ER visits 80%. I stopped for a bit and I said, this isn't rocket scientists. It just takes a lot of hard work, and it takes this team. We also hired a mental health provider that worked out of our office. Never made any money on that. In fact, we lost money, but it was a good thing to do, and it was really helpful for patients, particularly because we don't have enough psychiatrists in this country, and we spend a lot of time in primary care doing mental health. But we could use a master's degree, social worker or therapist, and that helped a lot too, dealing with people's mental issues that had these chronic diseases. So then I said, if I can influence you at all, I said, over those 10 years, I lost $100,000 per year because I wasn't taking care of those people in the hospital. That was almost pure profit for me because there was very little overhead in that kind of work. But I never got rewarded one extra dollar for all the money I lost and all the money I saved Medicare. The people on the other end of the phone said, yeah, we're starting to realize that, but we're working on it. Well, I still haven't seen an extra dollar. They're not working on it hard enough.
Benji, too, is clear-eyed about primary care's financial constraints, as well as the requisite hard work. But to him, the many benefits make these trade-offs well worth it.
The biggest one for me is to reject the anonymity that we can silo ourselves into. And to do so, you must accept the burden of being the physician. But in turn, you get a beautiful exchange. People look to you as a figure in their community that they can ask questions, admire. And that I would take any day over the Corvette or the, 3-story house or the yacht. Those things mean nothing to me. Now, that's because in my individual universe, I've learned enough about myself through experimentation, through observation, through reading has been an incredible part of it, through reading, that is my passion. The secret is I would do family medicine for free if I could. If I could have my means of survival and some pleasantries, mainly first edition and signed books, that would be nice, accounted for, I would see patients for free. So specifically ingraining myself in my community. When I was in that town in Mineral Wells, we were working hard. We were tired. We were running all over the place, from nursing homes to home visits on ranches to farms to the clinic to the hospital. But whenever I had a moment when I wasn't studying or reading, I would go and walk around in the small downtown. I would go to the local hotel and ask them what activities were coming up. What are some good restaurants to try? I would participate in the local 5Ks. And that brought me so much joy to see that my neighbors were also my patients and my patients were also my neighbors, that I was really part of this place. And for me, at least, that could make up for the hours, that could make up for the lack of sleep, knowing that people have granted me that trust and that privilege to know some of their deepest woes, but also their highest victories.
I felt so inspired hearing both Ed and Benji describe their passion for primary care. And in fact, I connected with Ed because he sent an email to our mutual friend, Kurt Stange, suggesting the podcast had been too negative about primary care. Dr. Stange was on the 3rd episode we did about misunderstandings, and he talked about his patient, Jim Bauer. And so you wrote him an email and you said, Kurt, I've read or listened to all of the recent NEJM articles, perspectives on primary care. Most have been so negative that it's no wonder no one wants to go into primary care. I listened to your interview and it gives me some hope. Dr. Rosenbaum should interview someone who's very passionate about their professional life. I'd be happy to talk to her. She should interview someone out in the real world. So that is how we met, and I'm very happy that we did. And I do think sometimes in academia, we don't understand what community primary care is like, community-based primary care, and that is part of the problem. But what did you find too negative? Like, I want to learn. I want to know if I have misrepresented something.
Well, I thought your audience should know that there are people that are really happy in primary care. And we've talked about this. I get up every day and I can't wait to get to the office. After 40 years, that hasn't changed at all. The time just flies by. I can't tell you the joy that it brings me to take care of patients and the impact I've had in their lives. There's no job like it in the world.
Given how much value people like Ed bring to their communities, I've had such a hard time understanding why we can't seem to create a reimbursement system that makes their work more sustainable.
I have been through several CEOs in our hospital system, and I was on a hospital board for 25 years. One of my favorite CEOs was a nurse that got a PhD in hospital administration. We would sit down and have conversations periodically, and she was aware of a lot of the things that you and I have talked about. And she said, I would love to have every one of our primary care physicians plug into what you've created. And I believe fully in the concepts that you're pushing and the way you take care of patients. The other side of this is, though, I don't sleep at night unless I've got 132 beds full of patients. And the reason that I don't is because that's the break-even point for our hospital. And if I don't have those beds full, then the hospital goes bankrupt and the community loses, a very valuable resource. So there's that dichotomy, how do you practice excellent primary care that drives costs down? And as you take care of people's mental health and you take care of their chronic diseases and you follow chronic disease management guidelines, utilization rates for all sorts of things go away. In fact, I'll tell you, we were a 2-hospital campus, and I was in the smaller of the 2 hospitals. And over that 10-year period where I was the largest admitter to the hospital, but when we got through with that 10-year period and we had decreased the admissions by 80%, we ended up shutting the inpatient service of that small hospital because we didn't have the beds full of patients. So there has to be some way to reward hospitals to do the right thing, but not be reimbursed so much by doing more procedures and doing more surgeries and keeping all those people in hospital beds. That's the real conundrum here.
If we, as a society, want a primary care system comprised of doctors like Ed, we need to address our reimbursement system, a system that for so long has denied primary care the resources that it needs to thrive.
Let's just talk about the healthcare dollar. And if we talk about it as the healthcare dollar, what percent of the healthcare dollar is actually going towards primary care right now? In the best of states, it's maybe 5, 6, tops 7%. And when you look at efficient, effective, good outcome healthcare systems, it is not at 5%. It's not at 6%. It's not at 7%. It's well over 14%. What you're looking for is what percent of the healthcare dollar is being invested in primary care. To get good outcomes, we need well above 14%. But right now, we don't even have a fraction of that.
I'm Lisa Rosenbaum, and that's next time on Not Otherwise Specified, a podcast from the New England Journal of Medicine. Our editor is Debbie Molina. Our producer is Mary Rose Madden. Adam Strauss is our audio engineer. And I also want to thank all of my colleagues at the Smith Center for Outcomes Research at Beth Israel Deaconess Medical Center. They've helped me to conceptualize this season and to identify the most pressing and unexplored challenges facing primary care. My new article series on primary care can be found at NEJM.org.